This study is a prospective randomized trial in a very special patient population and was done in an environment of very competitive recruitment with many other studies. Nevertheless, this study managed to recruit patients into binimetinib, the MEK inhibitor, in a randomized way to a chemotherapy, a standard chemotherapy that is used worldwide, which is called dacarbazine. The randomization and the patient populations worked nicely, so we have two very comparable groups, and the results are positive. We have a positive impact on progression-free survival, though this means patients that are on binimetinib have a better outcome. The disease is under control for a longer time, significantly longer. The hazard ratio is 0.62. This means a close to 40% improvement overall. And this is especially relevant for patients that are treated with immunotherapy, because nowadays most patients start with a first-line immunotherapy treatment, and unfortunately 50% of the patients fail. So for these patients it's important to have other options. Therefore we did a detailed analysis of the patients that had prior immunotherapy, and in this patient population the benefit was even greater than in the overall population. So the median progression-free interval during binimetinib was 4.6 months versus 1.6 months. So the difference is even better. The other question is, how does binimetinib impact on the tumor burden? And it does much better. There is a better response rate, and also the disease control rate is better in the binimetinib group. So taken together, all these data show that we have now an alternative to the chemotherapy. I think chemotherapy is of very limited value in patients with NRAS-mutated disease, but unfortunately in general in melanoma. So in patients that fail immunotherapy, we can now offer a new medication, binimetinib, for patients with NRAS-mutated melanoma.